Good afternoon, everyone. So I'm a rheumatologist, and we do use steroids. They are the anchor drugs. So steroids are, widely used for all inflammatory connective tissue diseases, right from rheumatoids to vasculitis to lupus and so on. And in fact, they play a very important role in the management of particularly life-threatening connective tissue diseases. Unfortunately, they do have their own share of side effects, which we all know. So it's all started almost 75 years back when the first patient received compound E, or which was cortisone, and with dramatic results. But within 3 years, the doctors at the Mayo Clinic, they listed down these common observations, and which were whether they can use it in patients with damaged joints with little inflammation, what is the optimum dose, can we reduce the dose fast, use single dose or multiple doses. And what they noted was inadequate supervision of patients. What should we do during time of surgery? So by that time, the side effects of steroids had already come into fore, and because of indiscriminate use. And now, almost 70 years from that day, these are the topics which we still read in our articles: to treat or not treat RA with glucocorticoids, a debate, and how do you balance the benefits and harms. So in 70 years, we are still struggling with what is the optimal way in which steroids can be used. And these are all the milestones. It's a very good slide, and it tells you most of the things about steroids right from 1940s to 2018. So it's a very big slide, and so from 65 to 94 there was what they have said, a period of relative scientific silence. But by 90s, short-term steroids, bridging therapy, and then all the guidelines started giving some criteria to how we should be using steroids. So in rheumatology, we have a lot of guidelines on how to use steroids in a host of rheumatoid diseases. For the students, whenever we interchange steroids, you should look at the equivalents. So if you are changing from prednisolone to deflazacort to methylprednisolone, these are how the doses changes. In 2002, we had the first, the nomenclature of steroids was finalized. So in practice, we try to divide patients, and how to use steroids in them in the terms of whether it's a low dose, whether it's a medium dose, whether it's a high dose. And accordingly, the rheumatological diseases are treated. So if you look at this slide here, so for rheumatoid, you normally require low or medium dose. Medication conditions like vasculitis, lupus, you would require medium to high dose. So the steroid dose for all these CTDs are pre-decided. So in some rheumatological disease, you don't require high dose. Like the joint manifestations of rheumatoid arthritis seldom requires more than 10 milligram of prednisolone. But you have a patient with rheumatoid with vasculitis, then the dose goes to 60 milligram. So all these doses are predefined, and in terms of trial data. During the last century, the treatment pyramid of rheumatoid was, the original pyramid where the DMARDs came later. So first was just watchful expectancy and DMARDs or steroids to be used in patients who have very severe disease. But beginning of the century, this pyramid became inverted. And now what we do is we early diagnose any of the rheumatological problems and start DMARDs. And steroids are basically used during flares or as a bridge, and you can increase, it can change DMARD, you can add biologics, and you can go to experimental treatment. So this pyramid is inverted now. And so in steroids, why we use steroids? They are very effective immunosuppression and anti-inflammatory molecules, rapid onset of action, cost effective, helps to attain disease control very early. So there is a window of opportunity in rheumatoid, just like we have a window of opportunity in heart attacks. So you have to treat rheumatoid during that window of opportunity. So when we talk about efficacy, we have enough trial data to see that they are efficacious, and we look at two aspects. One is controlling disease activity, and secondly, delaying the progression of joint damage. So EULAR, they specifically looked at the steroids since 2010, and the low dose steroid has been shifted to short term. So you can use any steroid, but you have to stop them by 3 months. So you can use oral, IM, IV, whichever way, but you should have an endpoint that you are going to stop them by 3 months. So short-term steroids are consider whether you initiate treatment or you change therapy. And you can use any regimes or doses, but so long you stop it or make an attempt to stop it is more important. The side effects are all known. So you have the positive side effects on the top and all the negative side effects, a host of them which we are very well aware of at the bottom. So there is truly no safe dose of glucocorticoids. But despite some undisputed beneficial effects, there are still fear of potential side effects, and that really has a limiting factor in private practice. So prolonged doses are always used with multiple side effects. And whenever you choose this steroid, you should look at the treatment related as well as the patient related. Both the things have to be taken into consideration. Again, these are all the side effects which we all know. And then EULAR and all the international societies, they try to give us some advice. And so long-term usage is 6 months. And what we really worry about are 4 side effects: osteoporosis, cardiovascular disease, hyperglycemia, infections. So they said that less than 5, the risks are acceptable. More than 10, a strict no. Between 5 and 10, it's a gray area. And when we look at this, these are the all the risk factors. So you have this positive, negative risk factors, and these are these preventive risk factors, which we should always tell the patient when we start them on steroids. So diabetes, exercise, weight loss, infections, vaccinations, osteoporosis, again, exercise, vitamin D, calcium, treatment, which we just spoke about, again cardiovascular risk. So if you tell all this patient all these things, the risk of whatever the side effect comes will be less. And then this is the guideline which we just spoke about. So whenever you put a patient on steroid, we always try to differentiate what the risk is going to be based on the FRAC scores or the DEXA scans. And once the patient is on steroid, you can decide whether the patient is into low risk, high risk, very high risk, and then the questions which you had asked, to decide which agents are to be used. You can always refer to these slides. And then this is all based on trial data. It's not something which I feel or any particular doctor feels. Since we are in an orthopedic setting, perioperative use also guidelines have been given. So previously, supraphysiological doses were covered during perioperative management, and they found out that it really does not make a difference. So the endpoint which were really looked at were hypotension and infections. Okay, so in terms of hypotension, it did not make a difference whether you give a supraphysiological dose or not. But when you give supraphysiological doses, the risk of hyperglycemia and infection increases. So here, patients with a higher GC dose were more likely to have diabetes and other complications, and this risk increased by almost 10% for every 10 milligram per dose. Wound healing can be affected even with low doses. So chronic low dose steroid also is a risk factor for wound infections. So patient education is very, very important. You have to really explain to the patient that why you are starting the patient on steroid, what are the potential risks, and how do you mitigate this risk. And you intervene appropriately. Also tell the patient about HPA suppression, because if you taper the steroid and stop it suddenly, they can get a flare of something like an Addisonian, and that can be perceived as a flare of rheumatoid. So that also you have to tell them that we gradually will try and stop it, and if possible you can always take a 8-time random cortisol. So consider all the comorbidities. So you have a patient with rheumatoid without any comorbidities, very easy to treat. But a rheumatoid with diabetes, with ischemic heart disease, with chronic kidney disease, on anticoagulation, the choice of therapies differs, So patients who are on these comorbidities, you require a very tight control to manage the risk-benefit ratio. And also always select the appropriate dose, Just because the patient has a rheumatological problem, you just don't have to put on an X dose, The doses which I mentioned, you have to, use those doses. And whenever the patient is there, you should always constantly review these doses. So this is my last slide. So we use all treatment with conventional DMARDs and a step-down approach in what we call as tit to target, timely tapering of glucocorticoids. Always remember, in sub-patient, you won't be able to taper and stop it also. And whenever you are unsuccessful, then you can always consider chronotherapy. So what is chronotherapy is that, the circadian rhythm is issued. So patient with rheumatoid, they have what is known as a relative glucocorticoid deficiency, which is worst at night. And that coincides with the cytokine surge. So in those patients, you can use this modified release preparations or a steroid at night. So finally, last slide is, Professor Frank Budgeret, he is the one who has done a lot of research in steroids in CTDs. And what he says is that every milligram that helps control disease is a good milligram, but every milligram we can spare is an even better one. Thank you.
Thank you.